being recorded, and slides will be made available at the end of the presentation for anybody who is interested. If you have any technical difficulties at this point, please try hanging up and dialing back to the webinar. If the problem persists, you can email me at pputnam@phlp.org. And for now, I will turn it over to my colleague, Amy Lowenstein.
Thank you, Pam. This is Amy Lowenstein. I am a supervising attorney here at the Pennsylvania Health Law Project. And today we are doing a webinar on getting ready for community health choices in Southeastern Pennsylvania. This webinar is aimed at professionals and advocates who are working with people who are getting the letters from the state telling people that they're going to be going into something called community health choices. And the goal of the webinar is to help you help the people you encounter who are receiving these letters be able to understand what their coverage is today, what's changing and what's not changing, and how to make enrollment decisions. Just as a reminder really quickly, in case you have trouble with the audio, right now the audio number is on the screen. And if you have any further trouble, please send a chat to Pam. So first I'm going to tell you a little bit about the Pennsylvania Health Law Project. We are a statewide nonprofit legal organization, and we're dedicated to ensuring access to public health coverage and services. This means we primarily work with people who are on Medicaid or CHIP, and it includes working with people who have both Medicaid and Medicare. And that is a population that is affected by the Community Health Choices program. What we do to help people on Medicaid and with Community Health Choices is we provide a helpline for clients as well as advocates. We provide free advice and legal representation, community education and training such as this one, as well as self-help materials. We have a monthly email newsletter that provides updates on health policy in Pennsylvania. And if you want to join, it's staff@phlp.org. And we also do policy advocacy with the state to increase access to quality health coverage and services. We do this for Medicaid General, and we do it for Community Health Choices as well. So we have a rather long agenda, but it's I don't expect this to take the full 2 hours, but there is going to be time for question and answers. And I want to start out by talking about Medicare and Medicaid briefly to provide an overview so we're all sort of on the same page about how they work and how they work together. Then I'll talk about what Community Health Choices is, the changes it brings, briefly benefits, the timeline and considerations for enrollment. We'll go through some participant rights and some implementation issues to watch out for, and then we'll take more questions at the end. But I will take a break for questions in the middle, and Pam is going to help out with answering those as well. Now, because this is Medicaid, there's a lot of terminology to learn. This is a reference. When these slides are available after the webinar, you'll be able to look back at this terminology slide to understand the different acronyms that are being used. But briefly, CHC is Community Health Choices. Dual eligible means a person enrolled in both Medicare and Medicaid. If you see LTSS, or long-term services and supports, that's a reference to the services people receive who are in waiver programs, so they might be aging or have disabilities, and they allow them to live at home and pursue goals for living in the community. And another way this is sometimes phrased is as home and community-based services. Long-term services and supports also includes nursing home services. If you see MCO, that's a managed care organization, it's a health plan. And NFCE, we'll use this a little bit. It means nursing facility clinically eligible. It's a standard used for people to receive Medicaid-funded long-term services and supports. So when people apply for a Medicaid waiver or want to get home care from Medicaid and other supports, they have to meet this eligibility standard of nursing facility clinically eligible. That doesn't mean they have to be in a nursing home, but it is the standard that's used. So I'm providing a brief overview of Medicare and Medicaid and how they work together, because 89% of the people who are going into Community Health Choices in Southeastern Pennsylvania are on both Medicare and Medicaid. So it's really important to understand the differences and how they work together and how they will and won't be affected by Community Health Choices. So first, what is Medicare? Medicare is federal health insurance for people who are age 65 and older, or people who have disabilities, who are on Social Security disability. The coverage is delivered in two different ways. Some people get it through what's called Original Medicare. They use a Medicare health insurance card, which is blue, white, and red. I have pictured here on the screen the new card that people have been receiving. It's still going out to some people. So if you have Original Medicare, that's how you get your hospital insurance, and if you go to the doctor, that's what you use. And then if you need prescription drugs on top of the Original Medicare plan, you would have a Medicare prescription drug plan, sometimes called a Medicare Part D plan. The other way some people receive their Medicaid is through private Medicare Advantage health plans. So this is a managed care organization. There are different organizations, insurance companies that run these. And with those, they would get the Medicare prescription drug coverage. There are some plans that don't have Medicare prescription drug coverage, and then you would get that as an extra thing. But for the most of them have all of the benefits of Medicare combined into one health plan. So then what is Medicaid? So Medicaid is a federal state in health insurance, so it's partially funded by the federal government, partially by the state, and it's means-tested public health insurance for low-income people, and that includes low-income seniors. What means-tested means is that there are income limits to get Medicaid, and for most categories of eligibility for Medicaid, there's also going to be resource limits, how much someone can have in assets. In Pennsylvania, Medicaid is sometimes called medical assistance as well. And pictured here, I have two cards. They're the access cards. One is green, one is yellow. And these are what some people use to get Medicaid. And just the green card also is for food stamps. We have learned during the Community Health Choices rollout that there are people who are on Medicare and Medicaid who don't really realize that they have Medicaid because their doctors are just billing, and they might have this green access card and say it's for their food stamps, but not realize that it's also their Medicaid card currently. So the way Medicaid works in Southeastern PA, and the reason I'm mentioning Southeastern PA is because Community Health Choices is rolling out in different places. So this is like right now, today, in Philadelphia, Bucks, Chester, Montgomery, and Delaware counties, there are two delivery systems for Medicaid, two different ways the Medicaid is paid for and obtained. The traditional way, which is not as common, is called fee-for-service, and this is where people use that access card that was pictured on the previous slide, and the state pays directly to the provider, so the state is directly billed. People who are on Medicare and Medicaid, they're also called dual eligibles, use their Medicaid this way. And also people who are on the Medicaid aging waiver, and anybody in a nursing home, and a few others will use their Medicaid this way. The providers, the doctors and others they see have to be willing to accept fee-for-service Medicaid, and they use the access card to get it. The other delivery system, which is a little more common for Medicaid, is through a managed care plan. That's a private health insurance plan that is paid by the state to provide the Medicaid services. So the state gives them an amount of money and then they provide the services. And most people get their Medicaid this way. They have to use the managed care plan's provider network and get referrals to see specialists. And there are two types of managed care plans that are used right now. There's managed care plans that are used for physical health. Those are called HealthChoices plans. And there are separate managed care plans that are for behavioral health, that is mental health and substance use disorders. And those are called behavioral health choices plans. In the Southeast, the physical health plans are Aetna, Health Partners, Keystone First, and United. And people have a choice of those plans for their physical health if they're going to use Medicaid managed care. The behavioral health plans are actually by county, so you don't have a choice. You're just put in a plan based on where you live. And in Chester, it's community care behavioral health. Philadelphia, it's community behavioral health. And Bucks, Delaware, and Montgomery, it's Magellan. People don't receive a card for this. The providers just know that if someone's on Medicaid, they know how to bill the plan. So Medicare and Medicaid work together for people who have both, people who are called dual eligibles. And the way it works is the Medicare card or Medicare health plan is primary. For services that Medicare covers, it pays first, and it pays most of the service. So this would be medical coverage, hospital coverage, and it also covers prescription drug coverage. So for Medicare, though, there are costs that individuals are supposed to pick up. We call that co-insurance or co-pays. And what Medicaid does for people who are also on Medicaid is it covers those. It covers what we call the cost sharing, so that people who are lower income don't have to pay 20% every time they go to the doctor. Instead, Medicaid covers it. So Medicaid will wrap around Medicare and pick up the Medicare hospital co-pays and co-insurance. That deductible people have. A deductible is where you have to pay a certain amount before your insurance turns on. Well, Medicaid's going to pay that so the Medicare can be turned on. Medicaid doesn't contribute directly to Medicare prescription drug coverage, but by virtue of having Medicaid, a person is qualified for what's called extra help with prescription drug costs. This means they're eligible for prescription drug Medicare plans that have no monthly cost, no monthly premium, and it reduces their cost that they pay out of pocket to very small amounts, their co-pays. The other thing to know about Medicare and Medicaid and how they work together is that Medicaid offers services that Medicare doesn't cover. Medicaid is more broad health insurance. It covers, for example, dental, vision, non-emergency medical transportation. That's transportation so that somebody can go to the doctor or come home from the doctor. It covers over-the-counter medications if they're prescribed by a doctor. And it covers long-term services and supports. So remember earlier I mentioned long-term services and supports include nursing home care, but they also include home and community-based services like a personal assistance aid to help out someone in their home, or modifications to someone's home so a person with disabilities can move in their home independently. So that's why it's really important for some people who are on Medicare to have Medicaid, because they need the extra services that Medicaid covers, and they need Medicaid to cover the costs that would be unaffordable. So now we're going to talk about what Community Health Choices is. So this is sort of what is new and what it is going to mean for people. It is actually a new delivery system, but it's a managed care type delivery system, and it's only for the Medicaid services that people receive. It's only for adults, and it is only for people in what's called a target population, which I will discuss later. It also, so what it's going to do is it's going to cover the long-term services and supports, nursing home supports, and home and community services, as well as physical health, going to the doctor, and for people who are not on Medicare, it'll cover prescription drugs. And what people must do then to get their Medicaid now, they're going to have to enroll in one of 3 managed care plans that are going to cover these services. So they're going to move out of however they were getting their Medicaid now into a new type of managed care system. In Pennsylvania, there are 3 plans that the state selected. Each will be statewide once Community Health Choices is across the state. There's Keystone First, which is also called AmeriHealth Caritas in other parts of the state, but in the 5-county region in the Southeast, it's Keystone First. There's a company called PA Health and Wellness, and there's UPMC Community Health Choices. The way it works is the state is giving what's called a capitation payment, a payment for each member, an amount of money that it thinks to provide services. So the plan gets the money, and then they provide all of the physical health and long-term services and supports that a person needs. And the state pays a little more if a person needs nursing home care or home care or home modifications. So then the plan gets this money, and they're in charge of providing all the services. And because they might have some people who they have more money than they needed, but they can then spend that money on somebody who's more costly. So it's sort of, they can spread the risk. It's still Medicaid, but it's Medicaid through a health plan. The plans then develop provider networks and they provide the CHC benefit package that is required by the Department of Human Services, which we will discuss. Now, I hinted at this before, but the way Community Health Choices is being implemented is in a phased rollout. So it already happened in 14 counties in the Southwest, and the Southeast is phase 2. So it starts January 1st, 2019. And then after a year, it'll start in the rest of the state. I mentioned earlier that there are target populations. So not everybody on Medicaid is going into this. Only certain target populations and only adults age 21 or over. And these are the groups. So there are people who are in what we call physical disability waivers, the aging waiver, the attendant care waiver, the independence waiver, many people from the OBRA waiver, anybody who's in a nursing home where Medicaid is paying for the stay, and most dual eligible, so most people who get Medicare and Medicaid. But there are some people who are not going over to CHC, who even might be in some of those categories. So we talked about waivers. Not all waivers are going over to Community Health Choices. Anybody who's in a waiver that's operated by the Office of Developmental Programs or getting base services from the county intellectual disability offices will stay in their waivers. So that would include people in autism waivers and the developmental disabilities and intellectual disability waivers. People who are in the OBRA waiver right now, some of those people are not going to meet the nursing facility clinical eligibility standard that I had mentioned earlier, and they just don't, their needs aren't as high. And even if they're over 21, they're going to stay in that waiver if they don't meet the nursing facility clinical eligibility standard, which is the standard for getting long-term services under Community Health Choices. So they'll get to stay. Also, residents of state-operated nursing facilities, including veterans' homes. And finally, LIFE program participants. So I want to talk briefly about LIFE. LIFE stands for Living Independence for the Elderly, and it provides long-term services and supports to people who are 55 and over. To be in a LIFE program, a person has to be in a geographic area where a LIFE program exists. So there are some places where there are not LIFE programs, and there's actually there are LIFE programs available in most of the 5 Southeast counties except a small portion of Chester County, and there are goals to make sure there's a program available there as well in the future. If somebody enrolls in this LIFE program, it's going to provide coverage for all their health care and all their long-term services and supports. It covers both Medicare and Medicaid. And really, it's another way of providing and managing a person's health care coverage. It's holistic as well. When a LIFE program becomes someone's Medicare and Medicaid, it provides all their services, and then the person then in exchange must use providers who are enrolled with a LIFE program, and they're generally going to access it at a specific location. So there'll be a facility where you might access all your behavioral health and mental and primary care and maybe a few specialists, and then there might be referrals to other specialists. So really, it exists alongside Community Health Choices and provides a lot of the same benefits, and it's an alternative to Community Health Choices. So what that means is if somebody is 55 and older and nursing facility clinically eligible, which is also the standard for LIFE, they have a choice. They can choose to go into a LIFE program, or if they're already in one, stay in one, or they can go to Community Health Choices. So a lot of people are going into Community Health Choices in the Southeast. It's about 130,000 people. And as I mentioned before, 89% of those people are people who are getting both Medicare and Medicaid. So there's going to be a lot of questions about what that means for people's Medicare and their Medicaid. And then you can see on this slide will also tell you that 36% of the people who are going in, they're in waiver programs. So they're getting long-term services and supports. So let's talk a little bit about what changes CHC, Community Health Choices, is going to bring. We already mentioned that it's a new delivery system, a new type of managed care delivery system for Medicaid services. So let's talk about what's going to change. And I like to do that by reassuring people about what is not changing. Medicare does not change. For the 89% of people who are going into Community Health Choices, they're still going to be eligible for Medicare. Their coverage options under Medicare and their Medicare plan choices are not going to change. They're going to continue to use their Medicare card or their Medicare Advantage plan card for most of their physical and behavioral health care. They're going to continue to use their Medicare prescription drug card for prescription drugs. And Medicaid, now in the form of Community Health Choices, is going to wrap around that. Medicaid under Community Health Choices is changing, but not all of it. What changes is how people get their Medicaid services. Now, may have used to go through the access card or a regular physical health choices plan or a waiver. Now it's going through the Community Health Choices plan to the target populations. But what's not changing is the eligibility and application process for Medicaid or for Medicaid long-term care. So if someone wants to apply for Medicaid, it's still the same process, whether they're want to go to a nursing home to get community-based long-term services and supports, be in a LIFE program, or just generally have Medicaid. That is not changing. It's only the way people in the target population get their Medicaid. So what happens is the physical health services are going to go through Community Health Choice plans. The waiver services are all going to be coordinated and managed and received through Community Health Choice plans. And nursing home services are going to be through Community Health Choices as well. Behavioral health access is changing for some, but not because it's going to be through Community Health Choices. The state is taking the opportunity of Community Health Choices rolling out to move a few remaining populations who were getting their mental health care and substance use disorder care with their access card, fee-for-service, into those behavioral health plans I mentioned before. And that's people who are in the nursing home residents or aging waiver participants. So they are going to experience a slight change in how they get their mental health care, although if most of them are duals, Medicare will still be primary. And nobody is getting behavioral health services through their Community Health Choices plan. So if someone's in Community Health Choices, their behavioral health services are going to be through the Behavioral Health Choices plan. So because this is a little confusing, I'm going to walk through a few examples of people in the community and how things are going to change. So we're going to start with Maria. Maria has original Medicare, so she uses that blue, white, and red card that I showed earlier. And she also has Medicaid. She doesn't get any long-term services and supports. So right now, when she goes to the doctor, she uses her Medicare card, and then her fee-for-service Medicaid, the access card, wraps around that. For her mental health care, when she goes to her psychiatrist, she uses her Medicare card first still. And the Medicaid behavioral health plan wraps around that. And when she goes to pick up a prescription at the pharmacy, she's using her Medicare prescription drug plan. The only thing that is changing for Maria is that when she goes to get physical health services, she's going to still use her Medicare, but her Community Health Choices plan is going to wrap around, and it's going to replace the access card for her. So her doctors are going to bill the Community Health Choices plan, and she'll also use it for some services that Medicare doesn't cover, like dental. Now this is Amir. He is also a dual eligible like Maria, but he gets his Medicare through Gateway Medicare Assured Plan. And he also has Medicaid and doesn't get long-term services and supports. So just like Maria, he gets his physical health, is his Gateway Medicare plus fee-for-service right now. He uses his Gateway Medicare and his Medicaid behavioral health plan to get mental health treatment. And because his Medicare plan includes prescription drug coverage, he uses his Gateway card at the pharmacy. The only thing that's going to change for Amir is that when he goes to his doctors, he's going to use his CHC plan card to wrap around his Medicare. So Medicare is still primary. He can still go to his Medicare providers, but instead the provider is going to bill the amount that Medicaid used to pay to the CHC plan. All right, so we're going to get a little more complicated and then end with the most complicated. This is Loretta. She is also on Medicare and Medicaid. She's dual eligible. But she's also on a waiver through which she gets personal assistance services. So she gets some help at home, showering and cooking and transferring in and out of bed. Right now, Medicare is primary still for her physical and mental health, and Medicaid wraps around that her fee-for-service access card. She uses her prescription drug plan through Medicare for her medications, and the aging waiver, which is the waiver she's in, pays for her waiver services and authorizes them. What's changing for her are a few things. First, for her physical health, she'll still use her Medicare, but the CHC plan is going to wrap around that. And the CHC plan is going to cover all of her waiver services. So her personal assistance services are going to be through the CHC plan. Her drugs will continue to be through her prescription drug plan through Medicare. That's not changing at all. And for mental health, because she's one of the small population that wasn't yet in a Medicaid behavioral health plan, she's actually going to use her Medicare card first, and then the Medicaid behavioral health plan in her county will pay the rest. All right. And now we have Juan. Juan has Medicaid only, so he doesn't have Medicare at all, and he gets it through a HealthChoices plan called Aetna Better Health. He's also on a waiver, but he's on something called the attendant care waiver. He gets personal assistance through that, just like Loretta. So right now, when he goes to the doctor, he shows one card, or the doctor has it on file, which is more likely, and that's his Aetna Better Health HealthChoices plan card. When he goes to therapy, his Medicaid behavioral health covers that. When he gets a prescription, he uses his Aetna Better Health HealthChoices Medicaid plan. And when for his waiver services, for the home care he gets and the service coordination he gets, that's all through a attendant care waiver. A lot's changing for him. Now, he's not going to be in Aetna Better Health. He's going to be in a Community Health Choices plan, and he's going to use that for his physical health, his prescriptions on all his pharmacy services, and to get his waiver services, to get his personal assistance services. The only thing that's not changing for Juan is that he's going to continue to get his therapy through Medicaid Behavioral Health Managed Care Plan. So this next slide is a summary of the changes that are happening to Medicaid. And what it does is, I kind of put this in, I'm not going to go through it in great detail, but I think people should print it out and save it, because when you encounter somebody and you're trying to advise them, this is a chart to help you know, like, what do they have now, what's changing. In orange, I indicate what's changing, which for the most part is that people will be in a Community Health Choices managed care organization, but also that some people are going to be moving into a behavioral health plan for their behavioral health services like mental health and substance use disorder treatment. So Pam, why don't we pause here, because this is, you know, when we've been counseling people, this has been the most confusing thing for people, is like what's changing, what's not, and helping people understand what they have. Are there questions we can answer?
Absolutely. We have a number of questions. So the first question I have comes from Andrea, and she asks if we could explain what are the types of Medicare and what is the difference. So Amy mentioned that people can get their Medicare through either original Medicare, which they use the red, white, and blue card, and that's administered directly through the federal government, or they can get their Medicare through a Medicare Advantage plan, which is a plan administered by a private insurance company. It's regulated pretty heavily by the federal government. It has to provide a certain amount of coverage, but oftentimes they can add extra benefits like vision, dental, gym memberships that the original Medicare doesn't cover. And usually they fold in some kind of prescription drug coverage as well. So those are some of the big differences. Heather Bogdan asked, what are the current income limits to Medicaid? Is there an income limit for extra help prescription coverage? The income limits to Medicaid vary a lot because there are a number of different categories you could fall into to qualify for Medicaid, and they each have their own income limits and their ways of calculating what income and resources count. It's also tied to the number of people in the household. So there isn't just one income limit for Medicaid. It depends on what pathway you qualify under. There is an income limit for extra help prescription coverage, and just looking at that now. That is approximately 135% of the federal poverty level with a resource limit. And so the federal poverty level, again, it depends on the number of people in the household. So if you have questions about a client and you're trying to see if they qualify for Medicaid or this extra help, they can give us a call and we can work through their specific situation as to whether they'd be eligible. Third question comes from...
Let me just jump in real quick. For what, I will share one eligibility standard, which is if somebody wants the home services, the home and community-based services that are normally through a waiver, the income limit is currently $2,250 a month, and they only look at the applicant, not their spouse. But there's also a resource limit.
That's right. Okay, we have another question from an anonymous attendee. And they are asking, should dual eligibles with an MCO plan show their access card to physicians as well as their insurance card? Is Medicaid considered second insurance? So I'll answer the second part of that first. When you have both Medicare and Medicaid, the Medicare is primary coverage. Medicaid acts as secondary coverage or as a payer of last resort. For dual eligibles, it probably does make sense for them just to show both their Medicare card and, starting in January, their CHC plan card. They shouldn't need to show their access card at the doctor's office anymore after January. Amy, did you have anything to add to that?
No.
Okay. Another anonymous attendee asked, how can members find out if their current physicians are in the network with the Medicaid health plan? And Amy is going to go into this a little more when she talks about the enrollment process, but the short answer is there's a couple different ways. One way is they can find out from the independent enrollment broker, Maximus, which is the agency that's supposed to navigate them through the enrollment process, and they should have that information. They can also ask their doctors or their providers which plans they are enrolled with or plan to enroll with. And then each of these CHC plans has a website where they may have that information on their network available and searchable. And they are all, as part of the agreement, they are all required to have a directory of all the providers in their network, which is supposed to be kept updated and sent to participants and available. Okay, Chris Compliment asked, can your Medicaid MCO be different from your Medicare MCO, and is that a problem? Again, Amy will probably get into more detail of this coming up, but the short answer is yes, you can have a Medicare Advantage plan from one company and a Medicaid Advantage plan or Medicaid CHC plan from another company, and they're supposed to work together. So just because you pick a plan for your CHC Medicaid, that does not mean you have to go with that plan it does not mean you have to enroll in that Medicare Advantage plan. So the CHC plan is supposed to work with whatever Medicare coverage you have. And then Amy, did you have anything to add?
Yeah, just quickly. So each of the companies that has a CHC plan is required to also have a Medicare Advantage D-SNP, which is a dual special needs plan. So it's a plan that's designed especially to provide Medicare to people who are dual eligible. And so people have the option of choosing the aligned D-SNP Medicare Advantage plan. So like Keystone Health will have a CHC plan and a dual special needs plan. They're supposed to work together and be aligned more closely. We haven't had a lot of clients who are in both, so we can't really comment on that. So people have the option, though, of having their Medicaid CHC and their Medicare CHC with the same plan, but again, they don't have to, and if people experience pressure to enroll in the Medicare Advantage plan that their CHC offers, we would like to hear about that because that should not be happening. People have.
We would absolutely like to hear about that. Absolutely. And a related question from Marianne Corey was, will recipients have Medicare and a CHC plan? The answer to that is yes. They will continue to have whatever Medicare plan they have now, whether that's original Medicare or a Medicare Advantage plan, and they're keeping that. That's unchanging. And then they will have a CHC plan for their Medicaid. A question from another anonymous attendee is, will members have different service coordinators? This we'll have more information on coming up, but the short answer is the participants will have an opportunity to choose one of these plans, and so they'll be able to see which plans, if any, has their service coordinator in the network. So if they choose a plan that has their service coordinator in the network, then no, they won't have to change service coordinators. But Amy's going to get more into detail on service coordination coming up. The other thing to note is for the first 6 months, there's a continuity of care protection for long-term services and supports, meaning for the first 6 months, the participant who has an existing long-term services plan, and the CHC plan has to continue paying for their current services at the current level with their current providers, including the service coordinator. So they will be able to keep their service coordinator for at least the first 6 months. And Amy, do you have anything to add to that, or will you be, I think you'll be discussing service coordinators in a lot more detail.
Yeah, I'll talk about it later.
Okay. Jennifer Stone-Wynn asked, will Health Partners, Aetna, and United still be available? I think you're referring to the Health Choices plans, the current Medicaid managed care plans through Health Choices from Health Partners, Aetna, and United. So this is only going to affect people who are already in a managed care plan. So this is probably going to be that narrow group of people who aren't on Medicare but are on Medicaid only and getting waiver services, and they have a Health Choices plan. For those people, they are going to have to choose the Health Choices plan, and Health Partners, Aetna, United, none of those are offering a Health Choices plan at this time. So if you've got someone who is in a Health Choices plan with one of these companies, and they're moving into CHC, yes, they will have to change plans. So those will not be available, though they will no longer be able to keep that plan. They will still be available for anyone else who's in the Health Choices population. Amy, did you have anything to add to that?
No, that's it. Just to emphasize, though, so for people who are not going to Community Health Choices, the regular physical Health Choices plans still exist.
That's correct. For people who aren't moving into Health Choices, Community Health Choices, yes, Health Partners, Aetna, United, those will still be available. And also, any Medicare Advantage plans from those companies will still be available. Okay, an anonymous attendee asked, will the Access card be obsolete? What about food stamps? The answer to that is no, the Access card is not obsolete. They will still use that for food stamps. The only thing is they will no longer use that to access Medicaid. So if they are using their Access card for food stamps, yes, they'll need to they'll need to hold on to it. They just won't need to use it at the doctor's office.
They also should hang on to it because it is proof of having Medicaid, and you still need it to register with the county in order to access Medicaid transportation benefits. So you need it to register there. And sometimes behavioral health providers will want to look at that just to know that you're on Medicaid. So definitely they should hang on to it even if it doesn't have the food stamps benefit, particularly because it's still needed to register for Medicaid transportation.
Thank you, Amy. Okay, Caroline asked, if someone has the attendant care waiver and medical assistance, when they renew their medical assistance, will they apply through the CAO or the independent enrollment broker? Will the CAO and IEB coordinate more closely? How does one enroll in a CHC plan? So I think Amy's going to discuss enrollment in more detail. The participants will choose a CHC plan by calling the IEB, which is Maximus, and that's how they'll get enrolled in a plan. Now, Amy, do you have an answer to this one as to what's going to happen when they need to renew?
Well, so first of all, generally, remember the application and eligibility process for Medicaid and Medicaid long-term services and supports doesn't change. So people still need to go through the independent enrollment broker if they're new to newly want waiver services. And they're still going to have to go to the county assistance office, which will handle the renewal. And for new people who are newly Medicaid, the CHC plan selection will be part of that enrollment process.
Thank you, Amy. All right, Marianne Corey asked, how does this change affect people in, I think you're KF, Keystone First VIP Choice / Health Partners Medicare, people who are in Advantage plans for dual eligibles. So CHC does not affect Medicare. So if they're in a Medicare Advantage plan, they can stay in that Medicare Advantage plan, and that's not going to change unless they choose to switch plans, unless they choose to either switch to the Medicare Advantage plan that's aligned with their CHC plan, or they choose to switch back to original Medicare. But for the folks who are in a Medicare Advantage plan now, they will continue using that plan just as they do now. And the only thing that's changing is they will have a different plan for the Medicaid piece of their insurance.
So Pam, let's do 2 more and then move on. And if we can't answer the questions now, we can see what we can answer at the end. And then we will also try to email answers to people who we don't get to at all if that happens.
Absolutely. So I'll take one more question. Jill Spector asks, can you please explain what happens to an individual under 21 currently on Medicaid for physical personal care and on OPRA waiver? So the answer to that is absolutely nothing, because this people under 21 are excluded from CHC. So nobody under 21 is moving into community health choices. So the person you're describing, it will have no impact on their insurance whatsoever. All right, and I think that's all the questions we have time for at this moment. I will be typing out answers so people can see the answers, and then we will get to the rest of these questions at the end, and I'll also try and add some answers as the rest of the presentation moves on. So thanks everybody for your excellent questions, and we'll have more time at the end. All right, back to you, Amy.
Thanks, Pam. So let's talk a little bit about CHC benefits. I'm not going to get into great detail about this because really the benefits are the Medicaid benefits, but I'm going to highlight a few things. So the Community Health Choice benefit package is all of the covered services for adult Medicaid physical health services. So it's the same as what people were getting when they were using regular health choices or their access card, and that all the plans have to cover that. It's also going to include the long-term services and supports. So any of the services that were available in the waivers that are moving into Community Health Choices will be available in Community Health Choices. This is only for people, though, who get a determination that they are nursing facility clinically eligible, which, as a reminder, doesn't mean you're someone who has to be in a nursing home, but it's an assessment of somebody's functional eligibility to see if they need the services. And nursing home care will be covered. Service coordination, I know there was a question about this, will continue. It was a part of all the waiver services, and it still will be. It's also going to be available to some people who have more a need for it. It's we haven't seen a lot of this, but even if someone's not getting waiver services, there may be some people who need somebody to help coordinate their Medicare and Medicaid and help them with doctor's appointments. So that should be made available, though it may take some advocacy if the person is not somebody who's getting long-term services. And in addition, each plan has some added benefits that they're offering. So this is the full list of the, without descriptions, but the full list of the 27 services that are going to be available for people who need community-based long-term services and supports. This list takes all the services that were available in the different waivers and combines them and adds one or two. So it's important for somebody, for example, in the attendant care waiver, they couldn't get home adaptations before, but now they can. If somebody needs a ramp to their house, now that's something that can be available. They'll be assessed for it and have to be approved, but it's available. So for some people, this is really going to expand the options for services in the community. The most common long-term service and support that people receive right now is personal assistance services. That's help with activities of daily living, such as dressing and grooming and transferring that people get in their homes and in the community. There's also non-medical transportation. So if somebody has a goal to get out in the community more, maybe go to religious services, the plan it has as an option, and you would apply for this, to cover non-medical transportation. So maybe a service to get you back and forth to the religious observances. Or maybe you want to go do bingo every Thursday. So that could be something where you could get non-medical transportation. Another one I want to highlight, which is new to all the waivers, is pest eradication. This seems like a small thing, but those of you who work in the community know that, like, if bed bugs are a huge issue, and if somebody starts to have a bed bug infestation, it can affect their health physically, but also providers' willingness to see them, aides' willingness to come into the home. So now pest eradication is a benefit that all the plans have to cover for somebody who's eligible for long-term services and supports. So those are just a few I wanted to highlight. So I also mentioned that service coordination is a part of the Community Health Choices package. It is actually a very key component, and it's existed in all of the waivers already, but the state is putting a lot of emphasis on the importance and central role that service coordinators will be playing. So a service coordinator has several responsibilities, and they include identifying and coordinating services that a person needs through not only the Community Health Choices plan, but also making sure it's coordinated with Medicare, the behavioral health plan, and any other systems. They are tasked with ensuring that participants get the services that meet their needs and preferences. So people who enroll in Community Health Choices have an opportunity to express their goals and preferences for meeting those goals. And the service coordinator will engage in what's called a person-centered service planning process with the individuals, help figure out what those goals are, how those goals and needs will be met, and how they'll be managed and coordinated. So that's a very big role for the service coordinator, and it's very important for the participants, because you want your goals to reflect what you want out of your life in the community or in a nursing home, and the services will be built around those goals. So who gets service coordination? As I said, everyone who gets long-term services and supports, including people in a nursing home, will get a service coordinator, as well as Community Health Choice participants who have a need for the service. It is provided in different ways. So right now, in the waiver program, service coordination is done by what we call service coordination entities. They're organizations that hire and train and provide service coordination to people who get waiver services. Under Community Health Choices, all of the plans, all three of them, have said that they are going to use what's called a hybrid model, where they use some external service coordinators and some who are working directly for the plan. And the external service coordinators would be at an entity that has an agreement with the plan. What is a little different is service coordinators, even if they're external, are not considered independent of the plan. The plans consider them an arm of the plan, so they're following the plan's rules and following how the plan wants to do things. So they really don't have the same independence that we might think that they have today under the waiver programs. And then I mentioned that there are added benefits. So there's going to be a plan comparison chart that people who get the Community Health Choices letter will receive. They're going to get this something called a pre-enrollment packet. It's going to contain a bunch of information about Community Health Choices. It's going to have an enrollment form and information about how to enroll. And it'll have a chart that lists all the services that are available. It'll list any copays, but frankly, the only plans that have, there's only copays for brand name prescription drugs for any services right now. And on the back of that plan comparison chart, there's going to be these added benefits. And each of the plans got to select some benefits that they're going to add that are in addition to what the basic Medicaid package and long-term services and supports package looks like. I'm going to mention a few of them later on as we go through and talk about plan selection, but I provided the links here because people are getting their pre-enrollment packets with this chart over the next, I guess they're supposed to be out by mid-October, so some people have gotten them and some people are waiting. They're sent in batches. So I know people are anxious to see these charts, so I want to make sure that people on the phone have access and you can share these with your consumers, your clients, or patients. This is just a quick glimpse at what it looks like. So I have on the screen a comparison of the three plans, and it says like one plan has adult dental. It does a little beyond Medicaid coverage for qualified participants. They'll get an oral hygiene kit. That's the extra benefit. Another plan gives a $500 yearly allowance for certain dental services that are not otherwise covered by Medicaid. So this is something that if all else seems the same, this chart might offer some insight into what a person might want to choose as their plan. So let's actually talk about the timeline and enrollment considerations, because you're all on the phone because you've been hearing about Community Health Choices. It's coming, it's coming. What's happening? So the Southeast Pennsylvania timeline, the notices and information to people started in late July. And then in late August, people started getting a mailing that told them that you are going to have to choose a Community Health Choices plan. You're going to be enrolled. If you disagree, you can appeal. But frankly, the only people who are going to be able to appeal are people who fit into those exceptions that I mentioned earlier. There have been meetings across the state. And then there's, going forward, the pre-enrollment packets are coming. They started in early September. They're going through mid-October. That's where you're going to get your plan comparison chart. I will tell you that the pre-transition notices, the notices that were mailed in late August to 130,000 people, did say they would get their enrollment packet in a few days. And it's actually, it could be like a month and a half. So you can let people know that it is coming. And if they don't have it by mid-October, they can call the independent enrollment broker. That number is at the end of this presentation. And as a reminder, the presentation will be made, slides will be made available after this. So people are going to have a deadline of November 14th to choose a plan, and if one of the three plans. If they don't choose a plan, they will be assigned to a plan automatically. And my understanding is that that's random, except for a few people. If somebody is enrolled in Keystone First's physical health plan, they'll just be automatically assigned to the Keystone First Community Health Choices plan. And that's not a lot of people, but for the most part, it'll be a random. And then really November 14th is sort of a soft deadline. If something happens and someone enrolls in a plan and they're like, wait a minute, I don't want to be in that plan. I want to choose a different plan, or they miss the deadline, we've been told that they have until December 21st to change the plan or select a plan so that it starts on January 1st. And then if they miss that deadline, they can change plans at any time. It just, they might have to wait like anywhere from a month to a month and a half to get into the new plan. So December 21st is the last day to sort of make a decision about what you want on January 1st. So there had been questions earlier about the independent enrollment broker, and that is Maximus. It's an entity called Maximus, and it does have a role in Community Health Choices. Its job is to provide information and answer questions about Community Health Choices and the plans right now and during the implementation process. This includes doing provider searches. So if somebody wants to know if their providers are in a particular plan's network or what networks their providers participate in, the independent enrollment broker is supposed to be able to search that. The independent enrollment broker also processes the actual enrollments. So when someone has a decision, they've made a decision, they can call there or send in the form, and any changes. They're also tasked with assisting people on CHC and others who are applying for long-term services and supports at home. So this is something that they've always done, well, not always, but this is something they've been doing for the waivers, is they're part of the process to determine if someone's eligible for a waiver. That will continue. So if a person is in Community Health Choices and they're not getting long-term services, but they want them, they're going to go through, the independent enrollment broker will do an assessment to see if they're eligible. Now, right now, the big thing that the enrollment broker is doing is the plan selection and the provider searches. And we do want to hear if people have trouble, like if somebody calls up and the independent enrollment broker tells them that they don't do special list searches or they're not doing any provider searches at this point, please let us know, or you can have your clients or patients call us because we do want to report any issues with the quality of the information that is being provided by the independent enrollment broker. All right, so how do people decide what plan to choose? I broke this out into the type of service because there's different ways of thinking about this. But if somebody's trying to decide, like for their medical doctors and pharmacy, the first thing you're going to want to know is like, what do they have now? And if there's somebody who's only on Medicaid, you're going to want to make sure that their medical providers are in the plan network, because that's how this is going to be the new way they access their medical providers. And that can be done through the independent enrollment broker. Independent enrollment broker has a website that has a provider search tool that needs a little bit of work. They're working on making it so you can actually search the provider name. And each of the plan websites is supposed to have a provider search function as well. Calling a provider can also help, but sometimes providers don't know whether they're contracted with the Community Health Choices plans. It's not necessarily something the providers know. It's the billing people might know, but that's what you're going to want to do. And also check the plan's formularies. That is only available by calling the plans or through their websites to see if the medications someone takes are covered. If somebody is on Medicare and Medicaid, it matters less that their primary care and specialist doctors are in the plan network, because Medicare is paying first, and they're allowed to continue to see the Medicare doctors they were going to. So if I go to my primary care doctor, who I've been going to for years, and she takes Medicare and has been taking my access card, once CHC starts, even if my doctor decides I'm not going to enroll in any of these plans, or nobody told me about the plans, as long as my doctor is still enrolled in the Medicaid program, she can bill my CHC plan, and the plan has to pay her for whatever Medicare didn't cover. So that's true for specialists and for primary care. So it really matters less whether the doctor is in network or not. That said, if the doctor is in network, will things go more smoothly? Probably. So it'll probably be easier in the doctor's office to bill if they're in network. The other thing is, there are some services that are not covered by Medicare, like dental and eye exams. So if you have a favorite dentist and you really want to keep going to this dentist because they've just done right by you, that's something that Medicare doesn't cover. So you're going to want to make sure that dentist is in the CHC network for the plan you choose. And then everybody should consider any extra services that are covered by the CHC plan. So, maybe you've decided your providers are all in Plan A. Let's see what the other services that they offer. And as I noted earlier, some of them are offering a little extra dental or vision beyond what Medicaid covers currently. And one of them actually offers some services at home to avoid nursing home placement for people who aren't actually eligible for home care. So they're offering a little extra. How that works in practice, I've not seen, but I wanted to note that. Okay, so what about for people, they've figured out whether the doctors are in, whether your pharmacy's in. What about people on waivers? Now remember, waiver services, those community long-term services and supports, are only covered by Medicaid. So here it does matter whether or not the providers of the waiver services are a network, or if the service coordination agencies are part of the CHC plans. But here's the rub. A lot of the, we encourage people to check with their providers to see what plans they're working with, but a lot of them may not know for several months into 2019 whether they're going to actually stick with that plan in the end. And remember, people can switch. So if your provider it doesn't participate in the plan you chose in the end, you might consider switching to a new plan if everything else would work out too. But you'd also want to consider extra services covered by the Community Health Choices plan. And some have extra services that are only for people who get long-term services and support. So one plan's extra dental and extra vision is only for people who are now getting waiver services. It's not for people who don't need those supports. And then finally, for people who are in a nursing home, there are some considerations. First of all, if someone's in a nursing home paid by Medicaid, on January 1st, the CHC plan has to pay that nursing home, even if that nursing home is not in the plan's network. So for people in a nursing home, the network of the CHC plan is really going to be important if they're going to outside providers. So if they're seeing specialists outside the nursing home, or if the nursing home brings in specialists who bill Medicare, this is when you're going to want to check. It's going to matter, again, more for people who are only on Medicaid, because CHC is going to be the only way their providers are going to get paid. Whereas people who are on Medicare and Medicaid, if they go to a neurologist who's not associated with the nursing home, and that neurologist takes Medicare and has been accepting Medicaid all along, that neurologist should be able to bill the CHC plan the person's in, even if they're not in network. And then, of course, you also want to consider extra services for people in nursing home. And what I mean here are not services in the nursing home, but actually community transition from a nursing home to the community is a benefit that all of the plans must provide. And they've actually done some work on this, and while there's a $4,000 limit towards community transition efforts in the regular service, some of the plans are offering a little more money towards that, or will do help towards paying rent when you get a new apartment. So that's, if you have somebody in a nursing home who's looking to get out, that's another thing to look at, is like, what are their community transition extra services like? Okay. And now, so you've been working with somebody, you're talking to them about enrollment, you've figured out like what they have now, you've advised them on what's going to change, you're looking through the provider networks, if they're on Medicare, they're you know, hopefully calm down and realize not a lot's changing except for their waiver services. But guess what else? During this time that people are getting all the HealthChoices communications, they're also getting inundated with mailings about Medicare open enrollment. This is when people get to switch Medicare Advantage or prescription drug plans. And they might be getting mailings or information, or their family members may, about the federal marketplace insurance open enrollment. So there's a lot going on in the fall. It's open enrollment season. And what I can say is this slide has the numbers for the independent enrollment broker, 844-824-3655, if somebody needs help understanding community health choices. But for Medicare, they can call Apprise, which is free counseling on Medicare choices. And since everybody who's on Medicare, who you'll be working with on the community health choices side, is also on Medicaid, they actually can switch their Medicare Advantage plan or their prescription drug plan at any time. So if they don't want to think about switching Medicare plans during an open enrollment but might want to do it in the future, they can wait. So, but I just wanted to warn people that there's a lot of mailings and a lot of discussion of open enrollment, and it can get quite confusing. Let's talk a little bit about participants' rights when they're in a CHC plan and during the transition period. Pam had alluded to this earlier, but there are continuity of care rights. This means the ability to keep services the same as they are in December going forward for a certain time period. And there are continuity of care rights under waiver services, nursing home, and medical and pharmacy services. Waiver services, and the big one being personal assistance services at home, there has to be continuity for 180 days, that's 6 months. So a person who's getting home and community-based services on January 1st gets to keep the services as is, and the providers, including their service coordinator, until July 1st, 2019. So if I'm getting 49 hours a week of personal assistance services, my CHC plan can't come in and change that to 35 hours a week during the 6-month period. They also can't say you need to switch who's providing that care. But on July 1st, provided they've done the proper assessments, they can seek to change the services I'm receiving. So 6 months continuity of care for waiver services. And if someone switched plans during that continuity of care period, they actually still get the 180 days or 60 days, whichever is longer. So if I switch plans on June 1st, and my continuity of care period would have ended July 1st, I actually get to keep the services in the new plan till August 1st. So it's very important. And this is also why service coordinators and waiver service providers might not know who they're going to have long-term contracts with, because right now the plans just have to work with them no matter what because of the right to continue working with your current providers. There are also continuity of care rights for nursing home care. I hinted at this earlier. It's really ongoing for someone who's in a nursing home paid by Medicaid on January 1st and is moved to CHC. If my Aunt Charlotte is in a nursing home being paid by Medicaid and she chooses a plan that that nursing home doesn't participate in, that plan still needs to pay the nursing home as long as my Aunt Charlotte is considered a resident of that nursing home. Now, if Aunt Charlotte comes home and decides she wants to try living at home and then winds up back in a nursing home, then she's going to have to pick a nursing home that's in her plan's network or switch. And then finally, for medical services and prescription drugs, there is continuity of care for up to 60 days after January 1 for any service that was already authorized or for an ongoing course of treatment. So if I'm going through an ongoing course of drug treatment that's supposed to end, you know, maybe it's like a 5-month course of treatment, I get to keep that for 60 days. And then there are assessments, obviously. It doesn't mean that they're necessarily going to get rid of it, but that's the right. So up to 60 days if the service is authorized or its ongoing course of treatment. But remember, that's more critical for people who don't have Medicare. For people who have Medicare, the plan's not going, CHC plan is not going to say what Medicare services you can and cannot receive. If you get a Medicare covered service and you see a doctor or provider who is Medicaid enrolled, the plan is supposed to pay that provider even if they're out of network. Okay. People also have a right to appeal decisions they're not happy with. The eligibility appeal process hasn't changed. So if somebody is denied Medicaid or eligibility for long-term services and supports, they would request a fair hearing through the Department of Human Services. For services in community health choices that the plan denies, refuses to authorize, reduces, terminates, refuses to include in a service plan, those can also be appealed, even if the decision is made by a service coordinator. So let's say you're developing your service plan with a service coordinator, and the service coordinator says, yeah, I know you say you want vehicle modifications, but I don't think they'll approve it, so I'm not going to put it in. Well, that's a denial, and that can be appealed. So the appeal is actually through the plan first. There's a plan grievance. And then if somebody loses their grievance, they can go to a fair hearing. When a service is denied, reduced, changed, or terminated, people are entitled to written notice and information about their appeal rights so that they know what to do and when to do it. And they also have a right to continue the benefit or service while the appeal is pending. So I gave an example earlier of being on personal assistance services. I get them 49 hours a week. Continuity of care period has ended, and my CHC plan says we have decided that you are going to get 35 hours a week instead of 49. They have to give me a notice. It has to be in advance of that decision. And if I appeal that decision within a certain time, prior to the date it's supposed to start or within 10 days, I get to keep those 49 hours through the grievance and through the fair hearing until there's a final decision. And hopefully that decision will be favorable to me. I do want to say that Pennsylvania Health Law Project is doing a lot of work around community health choices now in the enrollment and implementation, but we also plan to make ourselves available for appeals, including eligibility appeals, as well as service denials and terminations. So that's just keep our number in mind. We've been doing some of that work in the Southwest and plan to do it in the Southeast as well. So I want to touch briefly on some implementation issues to watch out for. So January 1st comes around, what might happen that we should be alerted to, and if these things do happen, feel free to give us a call. During the transition, we are concerned about problems at the pharmacy and also with Medicare providers. These were some of the issues that came up in the Southwest, and we're hoping they're less, but we don't know what's going to happen. So at the pharmacy, people who are on Medicaid have to show their CHC card. The access card that's been on file with the pharmacy for years or the Health Choices plan card is not going to work. So making sure the pharmacists know that to ask, I don't know if they're going to ask for the CHC card, but participants should bring that card and say, this is my plan now. people who are dual eligibles on Medicare and Medicaid actually do need to use their Community Health Choices card at the pharmacy for some things. So I'm going to give some examples. So if somebody gets prescribed over-the-counter medication, such as aspirin, if they want Medicaid to cover that, they're going to have to use their Community Health Choices card, because that's not something Medicare covers. There are also a few medications, a few drugs out there, such as some of the oral chemotherapy drugs, that Medicare Part B covers. Medicare, they use your Medicare card for, not the prescription drug card. And those come with a cost. So Medicare covers it, and there's 20% owed by the recipient. Well, if they're on Medicaid, Medicaid pays that 20%, and that's going to be the CHC card starting on January 1st. So they're going to want to bring the CHC card. The other thing that we're looking out for and want to hear about are Medicare providers who are not getting paid by a CHC plan. As I mentioned, the CHC plans must pay what Medicaid would have paid towards doctor's visits, even if the provider is not in network, as long as the doctor is willing to bill the plan and is just generally enrolled in the Medicaid program. So we do want to hear about these issues. What we advise people is when they go to the doctor, bring all the cards, and or go to the pharmacy. Just make sure you have all your cards with you, the Medicare card, the prescription drug card, the CHC card, so that the pharmacy or doctor's office can help you work out which one is the one they need, or ones they need. So after transition, going forward, and a little bit during the transition period, we are looking out for things like inadequate notices. So if somebody gets a notice that just simply says we're reducing your personal assistance services and it doesn't give a reason, well, that's not adequate. Or if it just says because that's all we think you need, or that's how we assessed you, that's not adequate. They need a detailed reason about why the services are changing. So we have seen some inadequate notices in the Southwest, and all three plans in the Southwest are in what's called corrective action with the state because their notices have been inadequate. So they haven't actually been allowed to issue any denial notices for several months now while the state reviews them. We're also concerned about inadequate person-centered service planning. And what we've seen are plans that don't show the individual's goals, people not getting copies of the plan, they're not giving an opportunity to sign the plan. So this is something else to watch out for. How good is the plan? And we're interested in seeing copies of plans. They can be redacted. Again, we alerted the state to some of our concerns, and all three plans are in corrective action for the adequacy of their person-centered service planning as well. We've also seen a lack of response to requests for new or increased community long-term services and supports, especially when it comes to things like home modifications. So if somebody will request a home modification, it's taken sometimes months or to get a response, or there's no response at all, and that's not appropriate, and because there really needs to be a timely response. And just as a reminder, people, even during that 6-month period where people can keep their services the same, they can ask for an increase or more services or new services. It's just that the plan can't reduce the services below what the person was already getting during that 6-month period. So when the slides are mailed out, you'll have this handy slide which has information on where to go for more CHC information and help, and that includes our helpline. We can talk to people about problems they're encountering with CHC, problems with the independent enrollment broker, talking through their rights, giving individual counseling, and also if someone's denied a service or item. They can also get help for enrollment information, sometimes from the service coordinator, or if they're in a nursing home, from the nursing home staff themselves. But this slide gives information about where to go for information about Medicare coverage, how to enroll in a plan, things like that. The slides are also going to contain links to the community health choices that the state website that the state runs, as well as our monthly newsletter. There's a listserv if you want to stay up to date on community health choices happenings that the state runs. They also do monthly webinars, and we generally provide updates on community health choices in our newsletter each month. Finally, I want to say that Medicare doesn't change. Community health choices is not about Medicare, it's about Medicaid. People who have Medicare and Medicaid continue to see their providers they've been seeing. They can stay in the same Medicare plan if they want to. Their Medicare prescription drugs are still going to be covered by whatever Medicare prescription drug plan they're in. Medicare is not changing. It's just Medicaid. And for a lot of people on Medicare, that just means who's paying the part that Medicare doesn't cover. And that is it. I think we do have some time for more questions, though, Pam.
Yes, and we have a lot of them. So the first question I have is from Nancy. She asks, will CHC cover current supports and services and the service coordinator for 6 months, even if that SCO is not in the plan? And the answer to that is yes. As Amy explained when she was talking about the continuity of care rules, the CHC plans have to continue to cover the existing LTSS plan at the existing levels and through the current providers for the first 6 months, and that applies whether the provider is in the network or not. After that 6 months, though, they do have to get their long-term services and supports through a provider in the CHC plan network. And so for waiver recipients, it's especially important to make sure that they pick a plan that has their current LTSS providers, service coordinators in that network. And if the plan changes, if the network changes, if the service coordinator is no longer with that plan, they can change plans at any time. Joanne asked, what if the provider of a Medicare Advantage plan is not in the MCO? How is the copay handled? And Amy discussed this a little bit, but for Medicare covered services, if Medicare's paying, the CHC plan must continue paying the Medicaid piece of the bill as long as the provider is Medicaid enrolled. If they're enrolled to accept any type of Medicaid, the CHC plan has to continue paying them, and that applies whether the provider is in their network or not. And if participants run into any problems where the doctor says, I'm not getting paid because they're telling me they're not in the network, they should call us because that could very well be wrong. However, it's important to note that for services Medicare doesn't cover, and so this could be things like such as dental, long-term services supports, especially vision, those providers do have to be in the CHC plan network. And so if it's a doctor who's not taking their Medicare, who's only being paid using the access card, they should make sure that those providers especially are in the plan network. Okay, an anonymous attendee asked, will anybody still use the access card for medical services? And yes, there are certain small pockets of people that will continue to get their Medicaid through the access card. And that's like people that are in certain waivers for folks with autism or intellectual disabilities. Certain people currently in the OBRA waiver, but not all. And then anyone under 21 is not affected by CHC. So if anyone's under 21 currently using the access card, that's not changing. Arlene asked, what if someone chooses a CHC plan and decides later on that there's a better one? As Amy said, they can change their CHC plan at any time. An anonymous attendee asked, is it correct to say that individuals between 21 and 65 who are not receiving waiver services or in a nursing home are not in the target population? And the answer to that is mostly correct, except if you're between 21 and 65 and you're dual eligible, you're going to be in CHC whether you're getting waiver services or not. There are a small portion of people who are on Medicare who are under 65, and if they're dual eligible, they would be moved into CHC. So many great questions. An anonymous attendee asked, what happens if a CHC participant not getting long-term services and supports requires service coordination? Amy, can you answer how a person who might need some service coordination could get that without, even if they're not on a waiver?
So it's not entirely clear how it happens. It's just there's notes in the contract that says they are supposed to provide service coordination to people who need it. And I'll see if I can find a better answer looking through the contract before the end of this call. But right now, what we would recommend, and I suggest this to somebody who might have some cognitive impairments or behavioral health issues that make it difficult for them to manage their own care, that they alert the CHC plan that they're interested in service coordination. And if they come back and say, no, you can only get that if you're getting long-term services and supports, we'd be interested in hearing that. But so far, we actually haven't heard of anyone who's gotten it outside of being in a nursing home or getting waiver services.
Thanks, Amy. So Sandra asked, will there be auto-enrollment for those who may not choose a CHC plan within the time frame similar to HealthChoices? As Amy alluded to, there is an auto-assignment process here, so if people don't pick a plan by mid-November, they will be auto-assigned. But as Amy said, they can change any time, and they can, they have until December 21st as a really hard deadline to absolutely make their to make their decision for what CHC plan they want to start with. So they will be assigned if they don't choose a plan, but they can change it. Okay, Janelle asked, I was under the impression that if a PCP provider is not in the MCO network, and I'm guessing you're referring to the CHC plan network, individuals will still receive full coverage through Medicare and Medicaid for the first 60 days. However, after the 60 days, the provider must be part of the MCO's network in order for the MCO to cover the remaining costs in the Medicaid plan. Could you help clarify this? As I explained earlier, for Medicare covered services, as long as the provider is Medicaid enrolled, the CHC plan is going to be expected to continue paying the Medicaid piece of the bill indefinitely, whether they're in the network or not, for Medicare covered services. For things that Medicare does not cover, where Medicaid's the only real coverage, they do have to be in the MCO network after that continuity of care period. Amy, do you have anything to add to that?
No.
Okay. Okay, and we got a couple other questions along that same line as to how does the cost sharing work for Medicare covered services. Caroline asked, how will CHC impact individuals looking to go into a nursing home for long-term care with funding from medical assistance? Could you speak to both individuals on an aging waiver and individuals in the community who only have Medicare and are spending down to meet medical assistance for long-term care financial eligibility requirements? Amy, do you want to take this one?
Yes, so basically the eligibility for nursing home care doesn't change. So there's nothing about Community Health Choices that's going to change the requirements, the income and resource requirements for being in a nursing home. It's actually it kind of like for somebody who's spending down to get waiver services, they should still be able to do that to get community health choices services in the community. And if they're spending down in the community, it's actually, you know, that they'll probably end up spending down in the nursing home as well to the eligibility rate, and then they actually only really receive a personal needs allowance. But the eligibility is exactly the same as it is today for nursing home services. It's just that they might be in a CHC plan when they go in as opposed to in an aging waiver. Then the county is still going to do an assessment of their eligibility. And the county assistant company.
Thanks, Amy. All right. An anonymous attendee asked if for those currently on Medicaid only, will new cards be mailed directly to their current residents? I would expect that when they're enrolling in a CHC plan, they will be providing their contact information, and then the new card and plan information, guidebook, all of those materials would be mailed to the address they put on file when they enroll in a CHC plan. Is that your understanding as well, Amy?
Yeah, whatever, they should give their mailing address if they have a different one, but they should be able to get it on their, it should be sent to their address of record, the address that's being used for the mailing.
Okay, and then an anonymous attendee asked, does the member contact Maximus with complaints or the DHS? And I think the answer to that depends on what the complaint is regarding. Amy, do you want to refresh our memory as to who they should talk to with complaints?
I mean, if there are complaints about how things are going, you know, with complaints about Maximus would go to DHS. We're also interested in hearing what's happening with Maximus. If there's complaints about the plan, that would be to DHS, Department of Human Services as well. And also you can file a complaint with the plan if you have an issue with the plan. I'm not sure if that answers the question.
Okay. All right, Chris had a couple questions. He asked, can a consumer change their CHC MCO at any time? I heard it was going to limited or quarterly change option. The answer to that is yes, they can change their CHC MCO at any time. I think there are procedures to where a person could be locked in if they abuse that process. But I think those rules are pretty limited. But I think generally, yes, the consumer can change their CHC MCO at any time. They're not locked in for a quarter. They're not locked into how many times they can change it. And then Chris also asked, does every dual eligible consumer have a service coordinator or only those in a waiver program? Anyone in a waiver program or receiving LTSS would have a service coordinator. In addition, other consumers can get service coordination if there's a need for it, even if they're not in waiver services. But not every dual eligible consumer would have a service coordinator. All right, Carol asks, are only full duals eligible for CHC? And the answer to that is no. There are other groups of people who are Medicaid only, but in waiver services who are also being moved into CHC. And I think there were a few slides discussing in more detail exactly who the CHC population is. So the slides will be available after this presentation, so you can go back and take a look at that and clarify who's in and who's out. And we're happy to answer any questions with that. Okay, and then Joanne had a couple questions regarding, will a person in a nursing spending down to get, will a person in a nursing home who's spending down to become Medicaid eligible have to be in a nursing home in the MCO's network? Let me see. Amy, do you have some insight into this question?
So I think this question is trying to ask whether or not somebody is still considered a resident of the nursing home if they're getting Medicaid paid, if their Medicaid's going off and on. But the way nursing home spend downs work is you pay it over. So my understanding is that if someone's spending down in a nursing home, which a lot of people are, they're paying over a portion of their income, they will choose a community health choice plan, and if they're a resident of that nursing home and remain a resident, the nursing home does not have to be in the plan's network. It needs to be accepting Medicaid generally, but as long, so it can't just be refusing to accept any Medicaid. But as long as it's a Medicaid enrolled nursing home, the person can be in whatever plan they want. But that's not true of new people who are going into nursing homes. Those people will need to find a nursing home in their plan's network or switch plans.
Okay. All right, and then I'm looking for other questions. Let me see. Loretta asked, at any time will members under the age of 18 with a disability transition to a CHC plan? Right now, CHC does not include anyone under the age of 21. I can't speak to whether the state may transition folks under 18 with disabilities into managed care in the future, but that's not CHC. CHC does not apply to anyone under the age of 21. Deborah asked, some of the waivers have specific services like chores, housekeeping, transportation. Are there going to be changes to what services are offered, and will some be removed? If yes, what does one need to do? So right now, each waiver program has a different menu of LTSS services available. Some, like the attendant care waiver, the list is pretty limited. Others, it's more extensive. What's happening with CHC is the CHC plan is going to cover one package of long-term services and supports for everybody, and it's a long list. Amy showed you the pretty extensive list. So it includes at a minimum all the services that are currently, it will include at a minimum all the services that they're currently getting through their waiver, and for some waiver recipients who are in ones that have more limited services, CHC could potentially open up, they could potentially be covered for a much longer, much wider range of long-term services and supports than they were before, assuming that they're found eligible and there's a need. So the answer is yes, the package is going to be changing. There are definitely going to be some new additions, maybe a lot of new additions to their coverage. At a minimum, they're not going to lose any of the services they're getting. Do you have anything to add to that, Amy?
No.
Okay. Arlene asks, do you expect families to be cooperative with these plans? If this is in effect in certain counties, have you dealt with any challenges with families? I will get back to you on that. I can't speak off the top of my head to the experience we've had in the Southwest, specifically with families interacting with these plans. But we could provide you more information on that if you're interested. All right. Deborah also asks, I understand that I can still continue with a Medicare doctor, but what about things like prescribing for items like incontinence pads? Recently, it was changed to be a Medicaid licensed doctor had to sign for it. Can my Medicare doctor now do it again? Amy, do you want to answer that?
I'm going to have to think about that one. I'm sorry. We'll answer you offline.
Absolutely. And then Deborah asks, they can change the number of hours I get? Who would do that? Why? And where do I get help fighting if they do? So I'm assuming you're referring to like nursing hours or personal assistance hours through a waiver program. And the answer to that is for the first 6 months, they cannot change that. But after that, the MCO can reevaluate, and if they determine that the amount of hours you are getting is not medically necessary, they can reduce that. And Amy discussed in some detail about where you can go for help. There is absolutely an appeals process for that. You can call PHLP, and we can help you with that. So if they do cut your hours and you disagree with that, you can appeal it, and there's resources for that. Okay. Let me see. We have a few more questions. Colleen asks, if someone has commercial health insurance through their parent as primary insurance, then Medicaid, is the CHC required to pay cost sharing to these providers, even if not in the CHC network, as long as the provider is Medicaid enrolled, as with Medicare? All right, so Medicaid is always the payer of last resort. So if the person has commercial insurance, health insurance, as well as Medicaid, then the commercial insurance pays first. Now, in terms of whether the CHC plan has to pick up the other piece of it, if they're not in the network, Amy, do you know that?
I don't know it off the top of my head, but what I will do is we will look this up. Is this anonymous or not?
This is Colleen Painter.
Yeah, so Colleen, I'm gonna look through the contract. I remember seeing something about third-party liability and how it works. We've been focused on Medicare because 90% of the people going into CHC are on Medicare, but let me see if I can find an answer to that as well. It won't be live though.
Okay. And then Arlene asks, will there be an out-of-pocket charge for anything, and who will be paying that charge? This CHC only changes the delivery system for Medicaid, and it has to cover, at a minimum, the same package of services that it covers now. So my understanding is whatever the cost sharing piece that is left to the consumer should not change. What if they're paying, if there's an out-of-pocket piece that the consumer is paying now, that's not going to change. If they're not paying anything out of pocket now and Medicaid is picking up virtually everything, that shouldn't change. Is that your understanding as well, Amy?
Yeah, I mean, I can add to this a little bit. So when you look at there are copays for Medicaid, and right now the plans, the way they're advertising is on their plan comparison chart, is really only copays for brand name prescription drugs for people on Medicaid. So it doesn't look like they're currently going to have copays for other services, but that that could change. I think they have some flexibility because they are allowed to charge the Medicaid copay. And then of course people who are on Medicare get their prescription drugs through a Medicare plan. Medicaid has nothing to do with it, and they're going to continue to pay whatever copays they had been paying under their Medicare prescription drug plan, which will include copays for generics and brand name drugs.
All right, and then last question, we have an anonymous attendee wants to know, will we put the Q&A in a written document to be available in addition to the slides? If we can figure out how to do that, yes, we absolutely will. Off the top of my head, I don't know how to do that right now, but yes, we will try and make those Q&A available if we're able to. And once the recording is available, you'll also be able to go back through to the to the end of the presentation and listen to the Q&A again. All right, and I think that is, oh, and then one more question. An anonymous attendee wanted to know, what is exceptional DME? Exceptional DME is exceptional durable medical equipment. These are pieces of equipment that are customized to the person.
They also have things that have like a high cost. So like I said, they define it as having an acquisition cost of $5,000 or more. So there's things like Howard and air flotation beds, air fluidized beds. I'm just looking through ventilators and related supplies, and augmentative communication devices. Communication devices. So those are some examples. And the Department of Human Services designates what the DMEs are going to be, the exceptional durable medical equipment.
All right, and I think that's, oh, we just had another question that an anonymous attendee asked, if I request a home modification, how soon will I hear if it is approved? How long do I have the home modification completed? This is an excellent question. The process is somewhat unclear, and depending on what type of home modification you're looking at, the process can take longer. I know Amy's had experience with a few home modification cases that have where there's been some delay, but I don't think.
This is what I was highlighting earlier, that home modifications in particular, we've complained about this to the state, but there have been delays in getting responses. So, putting in a home modification request and hearing nothing for a month would be problematic, because you should at least get a response and know what, a request for additional information. But there are no clear time frames. We're just kind of using judgment and we're trying to push the plans to act more quickly. But there's nothing in the contracts that actually tells the plans how quickly they have to provide them.
And I think that's all the questions we have for now, and we are coming up at noon. So if you have any follow-up questions, you can email us after this presentation. Amy's email is alowenstein@phlp.org, and mine is tputnam@phlp.org. I'm going to put this in the chat box. It's also on the second slide. So we are happy to take any of your questions. You can call our helpline or email our staff email that's up on the screen right now. And we are happy to continue answering any of these questions. And then we will also be sending around the slides and information on the recording once it's available.
We're also going to send out a survey, so we'd really appreciate it if you could answer it. It helps us improve our presentations and helps us identify what other presentations would be helpful to people going forward. Thank you very much for your time.
Yep, thank you all, and have a great rest of your day.